Okay, so thank you all for sticking with us all this long. Bridget and I were just texting that we thought this day has gone by so quickly already. We have one more session, and last but not least, for sure. Somebody already did it for me. Thank you. Last but certainly not least, we have some research updates by Dr. Kim Anderson. She is the one to go to for anything research. She is my supervisor. I'm learning a lot from her. So Kim, thank you so much for being here and for presenting today.
Thank you. Let me see if I can share my screen. And let me get this. Okay.
Perfect.
All right. Just make sure my picture is not blocking anything. Okay. Thank you, Megan and Bridget, for inviting me to speak today. And I'm so happy to be able to talk to everyone about our research updates. And there's been such great topics on everything that all the different speakers have spoken about today. I am a professor in the Department of Physical Medicine and Rehabilitation at MetroHealth and at Case Western. And like Megan said, I'm also the director of the Northeast Ohio Regional Spinal Cord Injury System. And before all of that, I had a spinal cord injury when I was 17. So I've been living with a cervical spinal cord injury for about 32 years now. And all of my experience in just living life with spinal cord injury actually has influenced my going into spinal cord injury research. So I kind of come at research from that multiple viewpoint lens. Okay, so today I'm going to start out with just a little bit of an overview about spinal cord injury, because I know not everybody understands the full picture about what we're researching and everything. And then I also want to talk just a little bit about the differences between research versus care. And then I'll spend the most of the time talking about the different spinal cord injury research studies, particularly at MetroHealth, when some of them we are collaborating with other locations in Cleveland. And then I'll end with some more resources. So this diagram here is the central nervous system. So you have the brain, and then you have the spinal cord that comes directly off the brain. That's the central nervous system. And then you see each of these little lines that are coming out of the spinal cord. Those are nerves, and they're peripheral nerves that come out of the spinal cord. And you see the little numbers here, C1, C2. These are all the different levels. So when someone tells you you're a C5 injury, that means that this area of your spinal cord was injured. So then we also have thoracic injury levels, and then lumbar and sacral injury levels. And basically anything above C8, so any cervical level or above, is called quadriplegia, or you might hear the phrase tetraplegia now. And basically anything after or lower than that falls into paraplegia. So if we look in a little bit closer, this little box right here, you can see this is part of the vertebral bone right here, the front side, and then back here you have the back side. And the bone protects the spinal cord. And so you only have this little part of the spinal cord, and this is the full bone area here. Usually when we have an injury, the bone will either get fractured, or the front and the back of the bone will dislocate or move in position. And then that will cause damage to the spinal cord, or maybe it just causes pressure on the spinal cord, and then the pressure can cause damage. If you look up and zoom in a little bit more, this is a diagram of the actual spinal cord. if you were to have cut it in half and looked down into it. All of these different colored areas are different nerve pathways within the spinal cord. It's not this simple, obviously, but in and out of your spinal cord, you've got all these different areas. And so one of the reasons why everybody's injury is different is it depends on what area of your spinal cord actually gets damaged, because usually not the entire spinal cord is damaged. But then you also see right here, you've got these little, what we call roots that come out of the spinal cord, and they lead out into that peripheral nerve, which is what you see over here as well. So you have sensory roots. They actually, sensation comes from out in the outer areas of your body into the spinal cord. And then that is processed in the spinal cord, and it goes up to your brain, and their brain sends messages back down. And then movement is this other area here. Movement signals are sent out of the spinal cord and down into those peripheral nerves down to your muscles. So this is an easy diagram to look at, but what does the real human spinal cord look like, and especially after injury? So these pictures here are all human spinal cords. They're all from individuals that passed away, but that they donated their spinal cord to science so we could learn more about it. And so this one here, these are all actually of the cervical region. This is what a normal spinal cord looks like if you were looking at it cut in half, like I was just showing you with the diagram. And then look, you've got all of these other different types of spinal cord injuries that can happen. It could be any combination of these. The three that are starred are actually the most common human spinal cord injury. The laceration injury is usually as a result if you happen to get a stab wound. But if you see all of them, there's some kind of spared tissue in the spinal cord injured area. So very, very, very rarely is the spinal cord cut completely in half. So even if the doctor might say that you have a complete injury, it just means that the signals are not getting through the injury area. There's probably tissue there, but something is preventing the signals from getting there. And then obviously we have many incomplete injuries as well. The good thing here is all of the other basic science that's going on to try to develop treatments that repair tissue. There's something there to work with. So it's not like having to grow nerve fibers completely across an empty space. And then lastly, about spinal cord injury, just in general, I want to tell you what actually happens inside the spinal cord. And this is a pretty good diagram. It makes it a little bit easier to understand what's happening. So first, when we have a traumatic injury, so say it's either from a fall or from a motor vehicle accident or motorcycle accident or a gunshot wound or anything, you've got that primary damage. And it's usually in a relatively small area. But what happens, that primary damage triggers all kinds of things inside the spinal cord with all the different cells, all the kinds of chemicals get released. And what happens is what we call secondary damage. So you actually get a little bit of an expansion of the injured tissue as a result of everything that is triggered after the primary damage. So you have primary damage and then you get secondary damage. You can also see that, so right here, these little purple lines, they are what we call axons. And a lot of axons make up the spinal cord. So some of them will be cut after the injury. But look, some of them are actually still connected above and below the injury. And also what happens usually after starts happening after a couple months, and then within 6 to 12 months, this scar tissue will form. And that's a hard barrier to try to get any kinds of nerve fibers to grow across it. But if you have, like I mentioned, we have incomplete injuries, that means that there's still some areas where there may be nerve fibers going above and below the injury. And then you'll have all different types of cells that die. These little yellow ones right here, you can think of these as the insulation around electric wires. And when some of these cells die, the nerve may still be connected, but it can't send a signal. And then you can see that also there'll be some areas where none of those cells have died. So everybody's got a whole mixture of things that happen in their spinal cord. And that's why there's so much variability in the way that our injuries present. And it's also why it's so hard for doctors and therapists to predict how any one individual person is going to recover. We know a lot about the population, but obviously everybody's individual. And so as long as you continue to try, you still have that potential to try to see some changes as a result of your injury. So then I want to shift just a little bit and talk about the difference between patients and participants, and talk about the difference between research and clinical care. So a patient is someone that is receiving medical care under a licensed healthcare provider. And that medical care is got some reasonable expectation to benefit the individual. So the care can be unique to each individual, but the overall goal is that for a benefit to that one individual. Whereas a participant is someone that's participating in a research study. So an investigator is either collecting data on them as a result of some sort of intervention that they're testing, or some sort of interaction with the individual. Now, an individual that is not living is not considered a research participant. So you've got a difference between patient and a difference between participant. And then what's the basic difference between clinical practice and research? Well, clinical practice are all of those actions that are taken by healthcare providers. And this is important, the intent to benefit, just like I said, the intent to benefit patients and to have a reasonable expectation of success. All healthcare providers take an oath of do no harm. And so that's why each decision that they make along with their individual patient has to be for intended benefit. Now, research also, we are not supposed to do any harm, but the actions taken by a researcher are really intended to answer a question, a research objective. And the information that is generated from those questions is supposed to advance knowledge to a larger group of people, not to just any individual people. So research helps us understand more about the population, and information from that can then eventually feed into practice. And there is a difference between clinical research and clinical trials. Clinical trials are just one piece of clinical research. So clinical research is any research involving live human participants. And it can be looking at a mechanism of disease, like how does spinal cord injury progress over time? So that could be observational. It could be looking at therapeutic interventions. Some of those interventions may already be approved for medical practice, but maybe they're trying to use them in a different way. Clinical trials, indeed, are a part of clinical research, or the development of new technologies. But then also you can have different population health studies, behavioral studies, and other outcomes research, or health services research. So research within a healthcare system to see how we might be able to better certain practices. So that's all really big. And I'm going to give you different examples of that in our research that we're doing. But a clinical trial is a very specific component of clinical research. And this is where you are testing a specific intervention. Now, it could be a drug, it could be a therapy, it could be a rehabilitation therapy or a device. And the intent is to demonstrate that that intervention is safe and it's effective. And then once those two are proven, the intent is to use that information to incorporate that intervention into healthcare or standard care. Now, usually the FDA is involved in this level of clinical trials. So there's a lot of people with spinal cord injuries that have participated in research in the past. And there's a lot of people with spinal cord injuries that are probably very hesitant to participate in research. I did a study back in 2016 asking a really large number of people with spinal cord injury from all countries, and we had all continents in the world participate in this study. And they told us what would be involved in their decision-making process if they were going to agree to participate in a clinical trial or not participate in a clinical trial. And these reasons here are all of the reasons that people gave us, regardless of their injury, regardless of where they lived, regardless of how long they had been injured. These were things that influenced them to want to participate in research. So obviously you may have a possibility of improving your function, you may not. But you usually will learn a lot more about your spinal cord injury, and you'll learn a lot more about your general health because you're interacting with a group of people that are really trying to learn more and more about the whole population. And one other thing people said is a real strong facilitator to them to participate is the opportunity to potentially help future people with spinal cord injury, even if they don't themselves experience an improvement. And then also you can usually get access to cutting edge care that may not be available or paid for by insurance yet. People felt it was by participating in research, it gave them a positive attitude to know that, they didn't need to give up hope. Also recommendations from other people with spinal cord injuries, recommendations from their doctors, recommendations from other spinal cord injury community organizations. And of course, having family support and encouragement is really important in people's decisions as well. So there's a lot of reasons why people decide to participate. And when you are ready to participate, well, how do you find out about studies? This is a new website that was created by a large community organization that is involved with spinal cord injury. And I'm going to play this video. It's about 4 minutes, and it will tell you all about this website and how you can go about finding studies.
We can't hear anything if it should be talking.
Hold on. Okay. Okay. Do you have to enable any audio sharing, Megan?
Not that I know. I don't know.
Okay. Okay.
It sounds like something's playing, but I couldn't hear what it was saying.
Okay. How about if I explain as the video is going on, so you can, because the screens will change. Will that work?
That sounds great.
Okay. So this is the website that you go to. It's called SCItrials.org. And you can put in your location, you can put in your injury level, or you can put in your injury severity or time post-injury. So here, it tells you extra information about the different sections. So once you put in your information here and you click Find Trials, it will pop up these different locations or studies. You can read a quick summary of each different study. You can see how far away they are from you. So there's all different kinds of filters that you can use. When you open up a trial, you can get this small or brief overview here of the trial. And it will also show what injury details are qualified. And then there's other questions that are down here that are pretty commonly asked. So it tells you all these different information about that particular trial. And then if you want more detail, you can click on this tab. And this may not be as user-friendly language as the trial overview tab. And then you will be able to go to the locations tab. So this green apply button right here, if you're interested in this in a study, you can click on that button and it will populate a form of your information and send it straight to the investigator. So this is the form. It would put in some basic information, how the investigator can contact you that you're wanting to talk to, and then your injury level, and then you press confirm and apply. Now, this information is not kept on the website. So once you click apply, it's gone, but you'll receive an email of this for your reference. And then if you haven't heard back from the investigator, then you can contact them directly. Some of the other things, it's really hard to talk while that's talking. Some of the other things is you can click on these different options over here. So say you're only interested in an exoskeleton study. You can just highlight that one button and then the studies that are involving exoskeletons will come up here. And then you can also follow trials that you're interested in or get rid of hide trials that you're not interested in. So it's a pretty easy website to follow, and it is SCItrials.org. Okay, so I apologize for that little technical problem there. So let's get into the spinal cord injury research studies that are at MetroHealth with our different investigators. The first one I'm going to start out with are actually my studies. So the spinal cord injury model systems. The spinal cord injury model systems, it's actually a grant, but it's from a federal program, the National Institute on Disability, Independent Living, and Rehabilitation Research. And they only award 14 centers every 5 years. And so we just recently were very fortunate enough to be renewed for another 5 years. And in order to qualify for this federal grant program, you automatically have to provide a very high level of clinical care. So from point of injury through inpatient rehabilitation, through discharge and long-term living out in the community. So this is everything that MetroHealth has, from our trauma center all the way out to outpatient care. So you automatically have to have that medical care in order to qualify. And then you will submit research information as well. So this is our team. Kim McKay and Megan Hammond are our clinical coordinators. And then Dr. Wilson and myself are the directors. And then Dr. Olson and Dr. Kelly are our co-investigators as well. So we all work together in all of our different disciplines to try to make everything as possible, as highest quality as possible for any experience with spinal cord injury. One of the studies that we contribute to is the National Spinal Cord Injury Database. So you could think of this as a population health study. And this database, every center contributes to it. They've been contributing data to it since 1973, I believe. There's 30 to 40,000 individuals with spinal cord injury that are in this database. And you're initially enrolled when you're in inpatient rehabilitation. And then we follow up with you at your first year after injury and then every 5 years after that. There's some individuals in the database that have been living with spinal cord injury for more than 45 years. And so this database really helps us learn a lot of information about spinal cord injury. And some of that information is here. So we know information about the new cases and the individuals that are living in the US with trauma-induced spinal cord injury. Some of these things that I pointed out in red, they've actually changed over time. And if we didn't have that database, we wouldn't know how they've changed. So initially, the average age of injury back in the 80s, 70s, and 80s was in the 20s. And now the average age of injury is 43. People used to think it was highly predominantly males. That number is still in the majority males, but it's decreasing. We're seeing an increase of injuries in women. It used to be that the majority of injuries were due to vehicular accidents. Now those and falls are pretty even as to causes of injury. And this right here, many injuries used to be complete. And now over 67% of the injuries are actually incomplete. Actually, that's really good because incomplete has much more possibility for natural recovery. And then we learn all other kinds of things like rehospitalizations, return to work, how much it costs to live with a spinal cord injury, causes of death, and then all the secondary complications that Bridget was telling you about. The other things that we have to do is we propose site-specific research studies. So the study that we proposed is to look at the feasibility of giving a drug, gabapentin, early as an intervention for neurorecovery and neuroprotection. And so for this study, you have to get out of your mind the use of gabapentin for pain. Think about this as a neurorecovery intervention. There's a lot of animal data and clinical data from registries that shows that if you initiate gabapentin early after injury at a low dose, low or a medium dose, and you deliver that from anywhere from 2 weeks to 4 months after injury, there is a persistent positive effect on motor recovery and autonomic recovery. Now it's a small effect, but it is persistent. So what we are actually doing is the first ever prospective dose exploration trial to test the feasibility of early administration of gabapentin as an intervention for neurorecovery. So if you look back at my spinal cord that I showed you early, this trial is really looking at, can we prevent some of the secondary damage? And can we induce any regeneration from some of those cut axons? Those are the two areas that we're looking at with this early design study. So we are actually going to randomize people into 3 groups. Some will receive a low dose, like I said here. Some will receive a medium dose, and some will receive no gabapentin. So now I know a lot of people take gabapentin for pain, and there's a mixed response. Some people absolutely hate it, and some people love it. And oftentimes, if it's severe neuropathic pain, people end up on doses that are much higher than this medium dose. The max dose, when you're talking about pain, could actually go up to 3,600 milligrams a day. And you do get a lot more negative side effects there. So we're trying to mitigate those side effects by giving the low and the medium dose. And this is the time frame. So people will be, if they decide to participate in this study, they'll be randomized to one of those groups and receive our medication within 5 days of injury. And then they'll receive that medication for only 90 days. And that's the only time where we have any kind of restriction on the medication. If someone's in the placebo group, we're going to try not to give them any gabapentin during that 90-day period unless they've exhausted all of their other pain treatment options and they really want to be on gabapentin. After that 90-day period, we'll still be following people for another 90 days, but we're not having any restrictions on any kind of medications. And we're trying to be very inclusive of this trial. So we're taking trauma-induced injuries, including gunshot wounds and stab injuries that are often excluded from clinical trials. All levels of injury, all severities of injury. People do have to be at least 18 years old, and they have to agree to participate if they're going to participate within that 5 days of their injury. Now, people do have to be able to provide their own consent. So that's why there is one exclusion where if somebody's got a traumatic brain injury that is severe enough to prevent them from being able to make decisions, then they're not going to be able to be allowed in this study. So what do we think we're going to find out? We haven't started this yet. We're going to find out, is it actually feasible to withhold gabapentin in that initial 90-day period and then give it in a very restricted way to promote nerve recovery? We'll get an initial impression of who responds and who doesn't respond. And we'll actually learn a little bit about how they respond. Is it related to movement recovery, feeling recovery, autonomic recovery? Does it prevent spasticity in any way? Does it have changes in their pain? Does it prevent those negative pain pathways from happening? We'll be able to learn all of that. And then lastly, some of the other activities that we do as a model center is we collaborate with the other centers. And we collaborate on these large multi-location studies. Now, I'm not going to go into the details yet, but the study that we proposed for that is involved in trying to improve bowel function for people with spinal cord injuries. We don't know which studies will be selected yet, but in October, we're going to have a meeting, and that's where we'll learn all of the different studies that we will be collaborating on. And the last thing, really important here, I've created a NORSIS, we call it the Northeast Ohio Regional Spinal Cord Injury System, a community advisory board. And we've got several different people with spinal cord injury already on the board, but we want to hear from our community living in Cleveland. And so if you really want to be part of this advisory board, please don't hesitate to reach out to me or to Megan, or for those of you that know Kim McKay. You can reach out to any of us by email and we can tell you more about what's involved. And you can be part of our activities. So now let's go on to some other studies that are involved in different types of studies with spinal cord injuries. So this is a study that I actually just finished enrolling individuals. This involved individuals with cervical spinal cord injury, and it was looking at this Mind2Move device, which is an external stimulation device. You stimulate different muscles in the arm, and you look at reaching and grasping after spinal cord injury. And the goal is to see whether or not this device is as good as or better than conventional therapy for arm and hand function. And this is once you're out of inpatient rehabilitation, so once you're out in the community. So there's 3 other centers around the country that are participating in this study. We just finished enrolling everybody, so we are actually finished delivering. We are finishing delivering therapy for all of our people now. And actually, I and the other investigators are blinded to all of the data. So I couldn't tell you what the results are if I wanted to, but we will know those results at the end of the year, beginning of next year. And we'll be very happy to be able to share that with our community. And if it proves that this device is more effective at reaching and grasping recovery than the conventional therapy, this may be something that we can help facilitate to get either in the inpatient or the outpatient therapies for MetroHealth. Another study that is one of my studies is called Perspectives on Recovery and Interventions to Restore Function Across the First Year of Spinal Cord Injury. And I have several collaborators on this. I really want to point out that in this particular grant, I have made it possible for the chapter to be a consultant to us. So we get their input every year, and then we're able to pay them for that, that expertise. In this particular study, we are interviewing individuals with spinal cord injury that have a newly acquired spinal cord injury. So both civilians and veterans, and we're also interviewing their caregivers. And we're really looking at how do people with spinal cord injuries and their support persons define and experience recovery and getting back into the community across that first year. And how does that experience shape their priorities and interests in different treatment options over that year and in different clinical trials over that year. And we are doing interviews. So we're interviewing 15 individuals that are civilians with spinal cord injuries and 15 veterans, and then their family members as well. And we do an interview when they're in inpatient rehabilitation, when they're around 6 months post-injury, and then at 12 months post-injury. And we're from these interviews, we get all kinds of information from individuals with spinal cord injuries and their support persons. And then we go through and we analyze this from all of these different topics and how that experience has been for different individuals. And this will really help us understand, how do people define recovery and reintegration? How does family support systems and other psychosocial factors impact successful recovery or lack of successful recovery? What kinds of barriers do people experience in the community over that first year? And then their decisions to pursue or not to pursue different treatments and experimental interventions. I'm going to tell you just a very brief amount of data that we've been digging into the analysis for how do people define recovery over the first year. And we're not finished collecting data yet, and we're certainly not finished analyzing data, but just for an idea of what we're starting to learn. So if we look at how do people with spinal cord injuries define recovery, this is a very big chart. What you see on the column here, this is each individual participant, and you can see what their injury was like. Now, this is only civilians here. We don't have the veteran data analyzed yet. And then you can see these are the themes that these individuals had, how they defined recovery when they were in inpatient rehabilitation, when they were 6 months after injury, and when they were 12 months after injury. And so you can see, for example, this individual here, he had a cervical injury. When he was initially injured, he defined recovery as going back to work, improving his respiratory function and mobility. Well, at 6 months, he defined it as motor recovery, motor functions. And then at 12 months, he defined recovery as time and actually being pragmatic about his injury and how to get his home environment set up for him to be functional. So this changes with each person, and we're seeing how that changes over time. And then similarly, from support persons, how do they define recovery? And you have same kind of a layout here. So this is actually, this is the support person for that individual that I pointed out on the other slide. So this support person initially defined recovery as motor function, and then at 6 months as independence, and then at 12 months as having home adaptation and accessibility. So we are getting all kinds of very, very, very rich information from these interviews. And the end goal is that we look at how civilians and how veterans experience that first year, how they recover, what kinds of barriers or facilitators they run in, and then their support persons as well. And then we'll use that information to create resources that will help other people in the future overcome those barriers. Another study now, no more of my studies, but electrical stimulation for bladder continence. Dr. Dennis Bourbeau in our group focuses on bladder and bowel function. This particular study is looking at an implanted stimulation device that is targeted for bladder continence. And this was actually released, approved by the FDA in 1998, but it's no longer created or built in the United States. You can get this very frequently over in Europe. The problem with this original system, they had to cut some nerves in order to make it be effective. What they're doing in this trial is using the same device, but they're not cutting the nerves. They're using a different stimulation pattern. So they're doing that to see if they can still get good bladder emptying and no leakage without having to cut those nerves. So for each slide that I'm going to present now, you'll see where you can access it on scitrials.org and a contact person for that study. This is a study that is being led by Dr. Kevin Kilgore and his team. It's called a multifunctional neuroprosthetic for restoring motor function. And you can see a diagram of that here. They're looking at it for arm function in this particular device image, but the goal is that it should be able to produce an improved trunk control as well. Now they're initially targeting people with cervical injuries because they're looking at arm function as well as trunk function. So this is actually a fully implanted device. This does involve a surgery. Just want to go back real quick. This device, the bladder one, is got some pieces internal and the controller external. So this multifunction neuroprosthesis is fully internal. So again, you can see where many more details about that study and how to find out more by contacting the team. Now there's also work looking at stimulation to restore cough, and that's being led by Dr. Tony DeMarco. And they're using a partially implanted, partially external system. They actually put a little stimulator pad over the surface of the spinal cord. And then a wire will, in the abdomen, you'll have a kind of like an antenna. And then on the outside of the skin, you put an antenna that touches that. So this is really looking at if they implant this stimulator onto a certain area of the spinal cord, and then you turn it on, can it actually help people cough better? And can they actually clear mucus better? And this has actually been pretty successful in several individuals with cervical injury. Now also for the lower extremity, Dr. Ron Triolo, he's primarily based at the VA, but they also work at Metro quite frequently. They're also doing a partially implanted, partially external stimulation device that they put in different muscles in the legs and actually sometimes in the back. And it enables people to move their legs. They can often do standing, stepping, and then the stimulation in the back helps with their balance. And if anyone actually remembers our keynote speaker from last year, Hanan, she actually has one of these research devices from the Dr. Triolo's team. Another thing that I work on with my colleagues in Miami, where I was before I came to Cleveland, is pain education. So we have spent several years doing interviews with individuals with spinal cord injuries that have severe neuropathic pain, and with their loved ones and with healthcare providers that treat severe neuropathic pain. We know this is an extremely difficult problem. It usually doesn't respond to medication very well. And what we've put together is this educational, there's two modules to it. And really, it's helping to educate people about why spinal cord injury can cause pain, but then also what things other individuals with spinal cord injuries do to make their pain manageable. And so we've had input from a huge diverse group of individuals, and we're finalizing both modules right now, and we will be releasing those for distribution pretty soon. I've done quite a bit of research to get user perspectives on what it's like to live with a spinal cord injury. People with spinal cord injuries know that. The doctors don't know that. And so we do surveys to help understand what it is that are the problems with spinal cord injury so that we can better direct research. So some recurring themes that have come out of that: bladder, bowel, and sexual function, some of the most important priorities for people with spinal cord injuries. And sometimes there's not a lot of research on it. So we're pushing for more and more research. People with spinal cord injuries, obviously we'd like to have a cure that makes everything go away, but that's not very realistic. So people with spinal cord injuries are open to getting incremental mobility improvements, whether that would be with the upper extremities, the lower extremities, or the trunk. And then exercise is very important to people, and obviously pain has been mentioned before. There's also a new study that's being led by Dr. Ann Bryden. It's really looking at the psychosocial impacts on caregivers as they're helping their loved one navigate through care transitions. So you might think the standard plan is acute care to rehab to home, but we know it's often way more complicated than that. And people will often go back and forth and in and out of these different things before they become stable. So they're really looking at how can caregivers be well-informed and better empowered in these different transitions to advocate for their loved ones with spinal cord injury, particularly across that first year. And then the last two studies I'm going to talk about are our collaborations with investigators, either at the Cleveland Clinic or at the VA. This one is a collaboration with Dr. Ela Plow at the Cleveland Clinic, and it's called Retraining the Brain. So they're actually looking at if you do non-invasive stimulation of the brain. So this little circle here is supposed to be a picture of the brain. So basically a device, a magnet, gets put over a particular area of the brain. And at the same time, you're doing rehab exercises. And so that's one group. Or the other group is they put the magnet over there, but they give sham stimulation or fake stimulation and then rehab. And the goal is to see if doing rehab while that particular magnetic stimulation is happening over specific areas of the brain, does that improve the effect of rehab? And then they will follow people for a certain amount of time. And so David Cunningham is our investigator here at MetroHealth that is working with this. And actually Dr. James Wilson is our physician that's working with David as well. And then lastly, stimulation of the bowel. This is being led by Dr. Bourbeau as well over at the VA. I think they may be able to do some of this at Metro as well. But it's really to look at a non-invasive electrical stimulation of the rectum and to see if that improves bowel movement as good as or better than what we're all used to using, which is digital stimulation or manual stimulation. And then we've, in collaboration with Dr. Bourbeau, we've actually been submitting some other grants where we can really develop more studies here at MetroHealth related to bowel function and bowel improvement. So I know I'm 1 minute over, and I just want to end with this resources slide. Our contact information is up here as well. And I just want to mention a couple things. Our NORSIS website is here on the MetroHealth website. I actually need to go in there and do some updates on it, but I will do that very soon. On the website, you can see a resource guide that we created early in 2020. And we really try to update this at least once a year. And it has everything we can find from our local area, as well as throughout Ohio and then nationally as well. And there's some really great resources in there. And then obviously all of our newsletters are there, and Megan shared that link earlier as well. We have a new spinal cord injury medical home clinic that Dr. Wilson is establishing. And actually next Tuesday is the first clinic. And this is really to try to streamline interdisciplinary care all in one location and in one visit, so you don't have to go all over the place. So there will be rehab, therapy, nursing, primary care, and research will be a part of that clinic as well. And then Megan mentioned the Connect In. We do everything we can to help the chapter be successful in peer support and anything we need to do to remove barriers for individuals, because peer-to-peer support, we just can't emphasize how incredibly important that is. And then lastly, call us or email us if you have any questions. We're researchers, we're used to digging and finding things, and we can help you find your answers, even if they're not related to research. We'll do everything we can to try to find an answer for you or find another resource for you. So I'm just going to leave this up, and I want to thank you for your attention, and if we have time for any questions.
Absolutely. If there are any questions, feel free to raise your hand, put it in the chat or the Q&A. But thank you so much, Dr. Anderson. And yes, reach out to us at any time if you need anything between the chapter's resources and our resources with the NORSIS team. We are more than happy to find anything that you need. Dr. Anderson will be presenting in our October meeting for the chapter with our chapter monthly meetings about the Perspectives Grant. So if you want to hear more information, have input in that, whatever the third Monday of October is, I don't have my calendar up, but the third Monday of October will be our monthly meeting. Reach out to me if you want more information or to anybody else. I don't see any questions, so I'm going to go ahead and stop recording, but thank you so much. That was full of awesome information on just spinal cord injury in general, research in general, and then specifically what we are doing here in Cleveland. So thank you.
Thank you.